Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, we're looking at the rapidly advancing field of genomics, which is becoming increasingly relevant to everyday primary care. I'm speaking to Dr. Jude Hayward and Dr. Imran Rafi, who are the Royal College of GP's joint clinical representatives for genomics. In this conversation, we discuss the most significant changes genomics is set to bring over the next decade, including the rise of pharmacogenomics and its potential use in predicting risks for common conditions, and how realistic the government's 10-year plan is when it comes to this. Jude and Imran also talk about some of the practical challenges facing GPs, such as how to handle patients presenting with results from direct-to-consumer genetic tests, the ethical considerations around data and consent, and the importance of ensuring advances in genomics help to narrow rather than widen health inequalities. Before we start, just a quick message about one of our upcoming events. MIMS Learning Live North takes place on the 26th of November in Liverpool. The event will have 3 clinical streams providing practical and insightful clinical education delivered by experts. For the first time this year, we're also running a GP business stream at the event, which I will be chairing, and where we'll be looking at key issues including how general practice can get the most from the 10-year plan, the skills practice managers need to ensure the practice thrives, and advice on finance and CQC regulation. For more information and to book your place, visit mimslearninglive.com. And if you come to the event, do pop over and say hello if you see me. I'm delighted to be joined on the podcast now by Dr. Jude Hayward and Dr. Imran Rafi, who are the Royal College of GP's joint clinical representatives for genomics. Jude is a GP in Bradford and a GP with a special interest in genomic medicine, and Imran is a reader in primary care and genomics at St George's University in London and was a GP partner in practice for over 20 years. Thank you both for coming on the podcast.
Thank you very much for having us, Emma. Delighted to be here.
Thank you, Emma.
What first sparked your interest in genomics? How did you become interested in this specific area of medicine? Imran, maybe we'll start with you on that one.
I think for me there was a couple of things. One was the Human Genome Project, which was looking to sequence DNA. It was just an amazing piece of science, the potential for future science and research based on those findings. The other at the same time was there was a book published in primary care called Primary Care Genetics by Annika Lucassen and Peter Rose, a GP in Oxford. And it was such a fascinating book, and I think I developed my interest further after that.
Jude, what about you? How did you get interested in this field?
If I'm honest, I don't think I can really remember when I started becoming interested in genomics. I always have been. Even opportunities at medical school, I had the chance to work in the lab that was working on the CF gene therapy, on the very early scientific discovery around that. And then when I did a biochemistry degree while I was at medical school as well, and was able to work on a genetics project there that looked at regulation of different genes. And I've just always been interested. I think it's the fact that genetics is so personal to people. It can mean such a lot to them around their identity and their family, and also the potential for it to be able to tell us things about health and all sorts of things about us has always fascinated me.
What work is the RCGP doing at the moment in the area of genomics, Jude?
So the RCGP has really been working in the field of genomics and working to support our primary care colleagues in genomics for a number of years. Started probably about 7 or 8 years ago now when we did a collaborative piece with the National Genomics Education Programme, and that led to the development of the curriculum, the area of the curriculum, the Genomic Medicine Clinical Topic Guide. So, really the college was extremely receptive and could see the potential of genomics, right that many years ago, and saw the importance in building from the foundation up. Since then, the college has supported the Genomics Education Programme to build a genomics toolkit. Again, that was a few years ago, and embedded within that was also webinars and toolkits. So the college is very engaged in delivering education material to our primary care colleagues, and at the strategic level as well. So we've been integrally involved in commenting on government strategy, and the council have regularly asked Imran and myself to present to them to keep them up to date with developments around genomics, such as direct-to-consumer testing and pharmacogenomics.
For many GPs, genomics might seem like a bit of a distant specialist field, but it's becoming more and more relevant. How would you describe its current relevance to the average primary care consultation today? Maybe, Imran, do you want to start with that one?
I'd probably argue that most GPs have contact with patients where genetics and genomics in particular are important for the future management of our patients. For example, taking a family history can give quite a lot of information about how genetics may be affecting our patient. Most GPs would know how to take a good, solid family history, which would then enable them to make a decision on the future management of our patients. As more and more patients go through treatment and management where genomics is a particular influence, the more we will learn about genomics and how it's applied to clinical conditions and how it can contribute to diagnosis and also prevention.
Obviously, there's been a lot of advances in medicine as a result of genomics. Looking ahead 5 to 10 years, what are the most significant changes you think genomics will bring to general practice? Are we talking mainly about pharmacogenomics, or will it be broader than that?
Yes, I think pharmacogenomics is really the big one to watch over the next 2 or 3 years. There is already information coming down to us from secondary care settings if in one particular situation where there's a gene test available to try and predict somebody's response to a medication called clopidogrel in the context of acute stroke. So I think pharmacogenomics is really going to be the big one to watch over the next 2 or 3 years. Also potentially coming down the line is the use of genomic information to help predict risk for certain common conditions, for instance, cardiovascular disease or cancer. But I think I would also be really keen to go back to Imran's previous point and say, for us in our daily practice, the key thing remains taking a family history and talking to people about risk, both of which are absolute bread and butter, and ensuring that we are picking up when somebody may be at risk of having a genetic condition or may have a significant family history and referring them on appropriately. So really just identifying, being aware and facilitating onward referral and management. And that, I think, will remain unchanged. And as these new advances do come, ideally they will be integrated into our existing workflow. So although they may impact more for our patients, our general working pattern should remain very much in common with our bread and butter practice.
While I was doing some research for this, obviously I came across the NHS Genomic Medicine Service, and that's aiming to enable the NHS to harness the power of genomic technology and science to improve health, and it's part of NHS England. Is there anything GPs should know about this service? What's it actually doing?
The NHS Genomic Medicine Service, previously people would be familiar with the clinical genetic services, which is where patients would go to have their risk assessed and be counselled around whether there was testing available and what the testing the result could potentially give them. So that still remains the core of the NHS Genomic Medicine Service. It's coupled now with advanced testing technology, and the labs called genomic laboratory hubs are really delivering a far greater breadth of genomic testing than ever before. And this is in line with the third strand of the Genomic Medicine Service, which is called the Genomic Test Directory. So this is a national document which aims to standardise the eligibility for gene tests or multiple gene tests called gene panels, and also the specialties that can request these tests. From the patient perspective, there is enormous breadth of testing that may be available, particularly in the areas of rare disease or cancer. But again, from our perspective in primary care, really our role is making sure that we're getting the right patient into that service.
And NHS England says it wants the NHS to be the first national healthcare system to offer whole genome sequencing as part of routine care, including for all children with cancer or children who are seriously ill, potentially with a genetic disorder. How soon is something like that likely to happen? And will that have an impact on GPs in practice?
There are very specified circumstances where whole genome sequencing is already offered, particularly for children who have complex problems that don't seem to be explained by single genes or other existing genetic testing. So it is already coming in. Again, from the primary care perspective, it may come in for other groups, but I think what we're going to see is potentially more children with a diagnosis of rare disease, but we would carry on applying our usual skills in care coordination to those children's care. And as other applications come in, we may see letters from secondary care saying that are so-called targeted therapies. So some of the whole genome sequencing is actually done on tissues, for instance, the cancer tissue. The result of that is used to guide treatment of that particular cancer. One of these early examples is a medication called Herceptin, which I think most GPs have probably heard of, but there's a whole wealth of targeted therapies out there. So we might just see letters starting to come through with more and more of these treatments.
You've mentioned the importance of taking a family history for GPs and how that's always going to be the bread and butter of what GPs do around this. Are there any key clinical red flags or family history patterns that should prompt GPs to think about a referral specifically for genomic testing?
Cancer is probably a good example. If you see family members developing cancer at a young age or developing associated cancers, for example, the breast and ovarian cancers as part of BRCA1 and BRCA2, associated cancers with those conditions. So they need to be referred for genomic testing at quite an early stage because the intervention may require to start treatment relatively early.
I think the other key group of people are people who may have another genetic condition in the family and they're wondering whether they've got a chance of inheriting it, or they might even be making decisions about whether to have family and how they might go about that depending on their risk. There is a lot of information around. There's a very helpful resource which is actually on the Genomics Education Programme website called GNotes that's very scenario based. There is some very helpful information there around the sorts of family histories or the sorts of conditions that may prompt a referral up to genetics. I think a key red flag, if there is a couple who are identified as being at risk of having a child with an affected genetic condition and they come already pregnant, then they should be offered an urgent referral so that they can have any conversation, counselling and testing and then really decide or really have access to information so that they're making decisions about their future family.
You mentioned counselling there. Is there enough support after people have gone for these tests to have this counselling to discuss the kind of consequences of the results of the test?
So the short answer is yes, and I think it's important to make a distinction between genetic counselling and often when we talk about counselling we may mean more broadly talking therapies. However, genetic counselling is a specialist skill. It's delivered by genetic counsellors and also by clinical geneticists, but also by anyone in the health service who is actually delivering a genetic test. And built into those services will be follow-up so that patients can get more information once they have a result so that they can talk through any implications for them and also for the family. And they also know where they may be able to get further support or information, for instance, from websites or patient support groups. If people are really struggling, then talking therapies can be helpful after that. But yes, absolutely baked into the genomics medicine service is genetic counselling and information regarding the results and implications after they get the results.
There are quite a lot of ethical considerations. Are there any particular ethical challenges for primary care as genomics and maybe, whole genome sequencing becomes more widespread? Is it about consent, data privacy, or potential for genetic discrimination? Are there issues that GPs are going to have to consider as we see more and more genomic testing happening?
I think the answer is yes to all that you said. Absolutely informed consent about what a genomic test might be and its potential implications. At the moment, for example, there's a moratorium where you don't have to declare the results of the genetic test, providing it's not more than £500,000.
There's a code of practice which has been published by the Association of British Insurers that really sets down that code of practice, and they will not seek deliberately to look for information of predictive testing. So predictive testing is testing somebody where there's a diagnosis already known in the family and somebody is having a genetic test to see whether they carry the variant that's running in the family. But GPs can be quite reassured about this because when they are requested for information around insurance, it does clearly say on the request not to include information about genomic tests. So in that specific scenario, there is absolutely information and a code of practice to back that up. What we would really hope and anticipate is that as the field of genomics grows, that the information around insurance and the infrastructure around that is really going to follow.
We need to ensure that there's equity of the opportunity for genomic testing. By that, I mean there are different ethnic groups who perhaps don't engage with genetic or genomic services as they might do. And it's quite important to work with the community to reassure that the results of any genomic tests will be secured carefully, encourage them to see the advantage of what genetic tests might be for them and their families.
Now, I was going to come on to talk about the 10-year plan in a minute, but obviously there's a big plan to expand how we use genomics. The government wants us to expand how we use genomics to really put an emphasis on prevention and this idea that it will be much more used to develop sort of risk scores and things for who is more likely to get certain conditions. And obviously that's a real concern, isn't it, with data privacy? I mean, do you see that those insurance kind of rules expanding to cover those things as well? Because that's not necessarily about genomic testing for specific conditions. That's more about using genomic information to predict risk.
I think that's a hard question to answer at the moment because it's very early in the development of using these within clinical practice. So a good example is using polygenic scores. So polygenic simply means that there's multiple variants, each with a small effect, but they together they can add to actually alter somebody's risk of developing a particular condition. And really the knowledge around cardiovascular disease, polygenic scores to predict risk, and in some scenarios around breast and prostate cancer are the most advanced examples of these, but they're not implemented as yet and certainly not rolled out widely because there's a lot of supporting infrastructure and knowledge that needs to follow these really. So I mean, I think everybody who is leading on this nationally and on the various work streams is very cognizant that this is something which is a key issue that the public will be interested in and will need to be addressed. And I think at the moment that's what we can say in that space.
One of the other things that's become more commonplace in recent years is this rise in commercial companies doing direct-to-consumer genetic testing. How do GPs deal with that if somebody comes in with a report from a commercial company which might contain some complex or potentially even quite alarming information? Is that a common occurrence? And what should GPs do in that situation?
It's definitely a true scenario that might happen. Genomic testing could be available through any retailer in a high street, and individuals could have their genomic printout without any counselling to support their decision making. There might well be scenarios where our patients come into our surgeries and ask for interpretation of these genetic tests. In anticipation of this, there was a position statement around over-the-counter genomic testing, which was produced a number of years ago, which has been updated to include looking at scenarios which affect pharmacogenomic tests. The bottom line, though, really is if an individual has a test done privately and the test is not a usual test done in the NHS, then they would need to go back to that private provider for interpretation or further testing. If the individual has had an NHS test, then they could be referred through pathways for genomic advice.
And I think the other key point that the position statement includes is around polygenic risk, because there may be polygenic scores returned within direct-to-consumer testing as well. But for us in general practice, we would just approach them in the same way that we would approach them if we were caring for them within NHS pathways. So, for instance, someone might come back with a polygenic score saying they were more likely to get atrial fibrillation. What we would be doing in general practice wouldn't change. We would just be giving general lifestyle advice around alcohol, and we would be checking their blood pressure and managing their other risk factors as well. So really, again, just application of our usual care.
Imran, you mentioned earlier health inequalities and equity of this. So how do we ensure that the rollout of genomic medicine and advances in genomics narrows rather than widens health inequalities? Is there any work being done to ensure equitable access across all communities?
There is. One such example is prostate cancer in ethnic minorities, particularly the Black population. And there is a study through the Institute for Cancer Research looking at this cohort and trying to get them engaged in being informed more about what prostate cancer genomics might mean for them and their family. I think clinical genetics in the past have worked hard to try and encourage communities to engage with genetic services, and that to include having community-based Macmillan nurses, for example, being asked by GP colleagues, primary care colleagues, to assess patients' risk, and other initiatives such as working with local community leaders, for example, to encourage them to get positive messages across communities. I think the answer is yes, there has been and will continue to be efforts made to help inform these patients and communities, and that can only be a good thing in terms of reducing inequity.
I've mentioned the 10-year plan very briefly earlier, and it does put a huge emphasis on genomics. You know, that's one of the government's 5 big bets alongside AI and other technological advances. in particular, it's how genomics will integrate with all this new technology to help improve disease prevention. How realistic are those plans? Are they achievable within the next decade, do you think?
I think that's a really good question, Emma, and I think you've summarised it in the question almost there when you said it's a 10-year plan and will we achieve it in a decade? So, none of this is going to happen immediately. A lot of the initiatives that are mentioned, are really into the very early stages of maturation and implementation of infrastructure. So I'm going to start that question really by saying, looking across the 10-year horizon, what is achievable? And even in that 10-year horizon, there is a great deal of aspiration there. I mentioned before pharmacogenomics, and I say that's probably the genomics initiative that's the most ready to go, but there may still be another 2-3 years before it's sort of broadly implemented. The other measures that I mentioned, so integration of polygenic information into risk scores, is going to take longer. It's not going to happen in the next few weeks or months. And I think the other key thing is the Genomics Population Health Service and the vision that at population level we may roll out testing more broadly for things like pharmacogenomics and inherited cancer.
Do you think GPs and others in primary care will need more training and education in genomics? I mean, do you see GP training changing in the future to include more on this, do you think, Imran?
Yes, education's been a key plank in the delivery of genomic medicine, education training, and individuals like Jude, who have worked with the genomic education program, have worked hard to develop materials that will help support colleagues at the front line. Genomics is part of the MRCGP curriculum. Resources that GPs find most appropriate are those, for example, at the need where they're seeing patients. Jude has alluded to a resource called GNotes, which provides educational profiles of conditions like prostate cancer, for example. Genomics education program, they provided funding for postgraduate education such as diplomas and also MScs in genomic medicine.
There's a lot of work going on to tailor educational resources for general practitioners and primary care. What we do know, as Imran's already alluded to, is that people tend to look for information at the point of need when the patient is actually in front of them. So I'm actually going to issue a slight call to action now. And I'm going to say, if there was anyone listening to the podcast who is involved in data informatics infrastructure, we'd be really very happy to talk to them and also to those in educational programs, because we know that in primary care, people learn best about genomics when it's aligned with the relevant clinical topics such as cardiovascular disease or cancer. There's some excellent work going on in the Northwest at the moment through a research study called Progress, and they're developing an informatics solution called Progress RX, which interacts with our usual prescribing software and informatics platforms. And it means that if somebody has had a gene test that helps guide their prescribing, the result is presented at the point that we prescribe, really concisely, one sentence following UK and international guidance with references if people want. And this is really what we want to see as genomics is rolled out, that GPs and primary care practitioners are given only the information that they need at the point of care. Nobody needs to know an awful lot of in-depth genomics, hard science or technology. And as we've alluded to already, in primary care, we already have the bread and butter to apply genomic medicine to clinical care. We just need that information as a source of education at the point that we're looking after the patient.
And Jude, obviously, one of the things I wanted to talk to you about, you're a GP with a special interest in genomics. I mean, what does your role in genomics actually involve? Because you actually work with the Genomic Medicine Service as well, don't you?
Yes, I do. So I work, my role was a GPSI role for many years. I am now officially a GPER, which is a GP with extended role. It's very exciting to say that earlier this year we published a GPER framework for GPER in clinical genetics and genomics. And this again was another initiative that was very much supported and facilitated by the college and sits within their GPER framework page. So I am now a GPER in clinical genetics and genomics. There's a few of us now around the country. We are growing slowly but surely, but my role in clinical genetics is mainly seeing patients who may have an inherited cancer predisposition syndrome. So I counsel for testing around some of the conditions that Imran's already mentioned, BRCA1 and BRCA2 and Lynch syndrome and others. And I also help to run care coordination for a particular rare disease called neurofibromatosis type 1 or NF1. My role also involves bringing the primary care skills that I have into the clinical genomics medicine service. And one example of that is my everyday use of contraception and women's health and HRT, and actually bringing that in and applying that to patients who do have a higher risk of certain cancers as a result. There's actually a great deal in common with primary care. The service that I deliver very much seeks to follow the same consultation model as general practice, actually. So I use a lot of my communication skills up in clinical genetics as well, really following that principle of shared decision making. Genetic counselling is not directive, it's shared decision making. So I can apply a lot of my primary care skills in that role as well.
Do you think this is a special interest role or an extended role that will expand in future? Do you think there'll be more and more GPs taking on a role in genomics?
That's what we would very much like to see. So from a clinical perspective, so the GPER role is generally a clinical role, and we think there's huge opportunity for GPs to upskill to that level should they wish, and to deliver services potentially within lipid clinics around familial hypercholesterolemia, or epilepsy clinics to deliver genomic testing, to support with pharmacogenomic testing, for example, as well. And there is a cohort of GPs and pharmacists and other primary care practitioners nationally who have gone through some of the programs that Imran mentioned, such as the MSc, who are really building additional expertise there. I think there is a huge role for primary care practitioners to develop a GPER role and contribute. What we need really is to have that awareness as services and commissioning models are developed along the lines of the 10-year plan.
Yeah, definitely. What advice would you give to GPs who are keen to take on an extended role in genomics?
Even medical students early on in their careers have heard about general practice and portfolio type careers where they've taken interest in a particular area or subject in medicine, as well as doing their general practice work. So the concept of extended roles is one that was well received in primary care. Although the role of the specialist GP with a specialist interest has been around, it's been a relatively small cohort of individuals around the country who have taken that title. And I hope with all the work, particularly the competency frameworks around extended roles that's been developed with Jude's help, for example, that this will encourage GPs to learn more about genomic medicine and apply their knowledge to primary care and frontline general practice.
And Jude, do you have any advice based on your own career path, how other people could get into that area of work?
That's a really good question, Emma. I mean, first of all, I would always encourage people to get into the field of genomics because I do think it is incredibly interesting. However, I think the challenge that we've had is that there isn't such a well-defined pathway as there is for potentially other GPERs. So people may be very familiar with GPERs in dermatology or cardiology, and the pathway is much clearer there. So what I would say is if you're enthusiastic, please come and talk to us. We can just help talk about what opportunities may be around. A big piece of advice that I generally say to people, because I haven't followed a very defined pathway as I've gone through different roles. At one point I was a Macmillan GP, at another point I was working from a public health perspective. So it's really looking for opportunities in other roles and areas where genomics is going to be really pertinent.
And both of you, looking ahead, which fields of medicine will see the biggest advances and changes as a result of genomics over the next decade? Is there any particular standout areas you think will be affected?
It'll be important to demonstrate the strength that genomic medicine brings to management and diagnosis. So, for example, with cardiovascular disease, you could develop a polygenic risk score that gives you extra information around what genomic information is readily available, and use that in combination with standardized risk assessment tools such as QRisk. It's been done in the research setting and has demonstrated that actually polygenic risk scores can influence management and decision-making by practitioners in primary care. So I think it's a question of more and more evidence accruing over time and then applying that knowledge to a clinical setting where it might make a difference to the future care of individuals.
Do you have any thoughts on that, Jude?
Yeah, I mean, I absolutely agree with Imran. From the primary care perspective, that is something which is going to be a growing field. Genomics is already firmly embedded within the oncology field, both in terms of inherited cancer and in diagnosis and treatment, as I've already mentioned. Pediatrics, it's increasing diagnosis for rare disease in pediatrics, many other specialties as well. But I think oncology and pediatrics are probably the non-genomic medicine specialties that have benefited the earliest from the advances in genomics. Another area that people don't always think about is infectious disease. With the pandemic and COVID pandemic, really the application of genomic technologies really pushed forward the understanding of the virus and also the manufacture of the vaccine much quicker than we've seen for other infectious diseases over time.
Finally, if you could give one sort of key piece of advice or a take-home message to GPs or other primary care staff listening today about genomics, what would it be? Is there a key thing that they should bear in mind or think about?
First of all, I think it is very exciting. Genomic medicine has huge potential, and it does have huge potential in many fields, including diagnosis and prescribing and so on. It is a very exciting field to be in and to understand more about. However, as it's implemented, really we will just continue to apply our core skills in family history, risk assessment, communication in order to bring the benefits of genomic medicine to our patients.
Yeah, is there anything you want to say about that, Imran?
I think genomics isn't going to go away. It's mentioned in the 10-year plan, but it didn't develop within the planning stage. It's developed many years ago, starting with the 100,000 Genome Project and all the learning that's come from that, including the research investment to support genomic medicine to take it to a clinical level. I think, rest assured, it is a definite commitment to the delivery of genomic medicine, which could help our patients potentially in many different ways.
Well, that's brilliant. Thank you so much for speaking to me today, and thank you for coming on the podcast.
Thank you, Emma.
Always delighted to talk about genomics. Thank you.
Well, that's it for this week. Thanks so much for listening, and thanks again to Jude and Imran. I'll be back next week when I'm talking to GP Dr. Callum Leese about promoting physical activity in primary care, why this is so important, and how it links to sustainable healthcare, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.